Hi, my name is Taylor Jones, and I'm here to do the first part of your newborn nursing assessment. Today we're going to be going over APGAR scores, vital signs, head, ears, and eyes assessment for the newborn. My email's down here if you have any questions. So just a brief overview. We're going to be reviewing our objectives, going through the material, doing a brief application of the APGAR scoring at the end, and if we have time we'll do some demos, but if not, we'll do those tomorrow in class. And then of course allowing time for questions if there are any. So our objectives today, by the end of this class, we should be able to describe the purpose and the components of the APGAR score, evaluate the normal vital signs of a term infant, describe the components of the head, ears, and eyes assessment, compare abnormal to normal findings related to vital signs and the head, ears, and eyes assessment, and then apply these findings and appropriately care for a newborn. So the APGAR score, this is a rapid assessment of the newborn initially after birth. It's performed at 1 minute and 5 minutes of life. This is just a basic assessment for us to determine if an infant does need resuscitation. It consists of 5 components: the appearance, pulse, grimace, activity, and respirations. The appearance is the infant's coloring, so there's coloring of their skin. If they're pale, if they're blue, are they pink? Normally we want an infant to be pink, but acrocyanosis, which is a pink trunk and face but blue hands and feet, is a normal variation of the newborn until 24 hours of life. Pulse, we just assess via the heart rate. We want it to be above 100, ideally. Grimace is a reflex irritability of the infant, so newborn infants can be gently slapped on their feet or wiped with a towel, and the way they respond to this irritation is an indication of how well they're doing. They should respond with a very loud, vigorous cry. Next is the activity, so the muscle tone of the infant. Infants like to resort back to that intrauterine positioning, which is fetal, so flex arms and flex legs. And then finally respiration, which is just chest wall movement, which we all can assess, which we have done on the healthy adults. Scores are from 0 to 10. 0 to 3 indicates severe distress. There is an indication for intervention to be done. 4 to 6 is moderate to distress. You can observe the infant, kind of stimulate them more, let them adjust to extrauterine life. But an intervention may be needed. And then anything above 7 or above, does not need any intervention. The infant is transitioning well and appropriately. The APGAR score is very subjective, so me and another nurse may not provide the same scores for an infant. That's why it's not a direct indication of morbidity or mortality for a baby. This is an example of acrocyanosis. You can see that this infant's feet and hands are paler than the rest of the body. And again, this is normal newborn variation until 24 hours of age. This is the APGAR chart that we actually usually have at the bedside. So each of the 5 things we listed are given a 0 to 1 to 2 score. And you guys all have this for reference. And actually, if you click on this, the APGAR takes you to a link that actually breaks this down for you. So, jumping into vital signs, we want to just do a general observation of how the infant looks. Are their hands and feet flexed? Are they pink? Are they crying? Are they moving their arms and legs equally? Next, we want to assess their temperature. You don't want to assess rectally. That's not recommended anymore. There's actually studies that's been proven that's not necessary. That used to be for assessment of patency of the rectum, but that's no longer indicated. Now we would just do an axillary temperature. Heart rate, which you want to inspect, feel for the apical pulse, and then listen there on top of the apical pulse for the heart rate. That's left midclavicular line and the 5th intercostal space, by the way. Murmur is a normal newborn variation. If you go back to a cardiac lecture, we know that intrauterine the heart is shaped differently for infants, and so extrauterine that transitioning period can lead to murmurs. Respiratory rate you want to observe for a full minute. Infants do not breathe rhythmically like adults do, so they can take pauses and have little shudders, and so you have to watch for a full minute for their respiratory rate. Vital signs, blood pressure is not indicated usually. If the infant has some kind of cardiac history or renal history that was visualized on ultrasound, that's when you would do a blood pressure, or if they're being transferred to the NICU. Weight, you want to use the same scale each time so you get consistencies in weight. Length, you want to measure from the top of the head to the heel of the foot. And you may need a second set of hands to kind of help you with that because the newborns kind of squirm around a little bit. Next is the head circumference, which you want to grab at the largest diameter of the head, which can be a little tricky since the infant's head can be molded, which we'll talk about in a second. Chest circumference, which should be about 2 to 3 centimeters less than the head circumference. Finally, abdominal circumference, again, not usually indicated for every newborn, just those newborns that have some kind of risk factors that makes you think there could be something going on abnormally with their intestines. Okay, moving on to the head assessment. Molding is a normal variation of the newborns. Birth is very traumatic. They come in through the birth canal. Their scalp is made to mold and bend, so it doesn't fracture when they're being born. Swelling, bruising are all okay. I'll talk about it in a second, but the caput succedaneum and the cephalehematomas are usually typically found in some newborns from a little bit more traumatic births. Fontanelles, there should be an anterior and posterior. They should both be open, soft, and non-bulging. Sutures should be palpable and not joined, and then the hair varies on ethnicity. So this is the caput succedaneum. This is actually a diffuse swelling of the soft tissue over the scalp. So it does cross the suture lines, and this is completely okay. This is just, a little bit of bruising and swelling. You just have to reassure parents that the infant's head and swelling will go back to normal after 2 to 3 days of life. This is a cephalohematoma, which does not cross the suture line. So you can see in the middle here, it is focused on one side. And this is actually a breaking of the blood vessels between the scalp and these soft tissue, between the scalp and the soft tissue above the scalp. This takes a little bit longer to resolve, about 2 to 3 weeks. But again, this is also a normal newborn variation. This is not a breaking of the blood vessels internally on the brain, which would be a subdural hematoma, something that would be way more concerning. This should resolve on its own. It does not indicate any type of brain injury. So for the ears, we're just visualizing their placement on the infant's head. The top of the ear should come and meet the outer canthus of the eye, so that you should be able to draw a line straight back. You want to make sure they're well formed. There's no skin tags or pits. Ears actually form at the same time as the kidneys, so if you do notice any abnormalities of the ears, that can be an indication you need to do a renal follow-up or renal workup. And then you should just make sure that the infant is responding to loud noises, responding to your voice. They do have a formal hearing discharge prior to being sent home from the hospital, but just take note of that, and if for some reason there is some worries there, we can do further referrals outside to audiology. You want to assess the ears, just observing for placement, equal spacing, roundness. Pupils should be equal, reactive to light, making sure there's no abnormal discharge, anything like that. Observing for the red reflex is very important. Taking the ophthalmoscope and just looking in each eye. If there is no red reflex, that can be an indication of a brain tumor, optic nerve tumor. So you just want to keep that in mind when you are doing your newborn assessment. Also, just visualizing the light reflex in both infants' eyes when you're doing the assessment. It should be equal. If it's not, that could be an indication of strabismus, which is a normal newborn variation. But just make sure that you reassure the parents that the one eye may be deviating a little bit more, but that should be going back to normal by 1 month to 2 months of age. Okay, so let's practice what we've learned. So I'm going to show you a video. This is baby Barrett. He's a 39-week-old infant born to a prima gravida mom vaginally. He's approximately 1 minute old. His heart rate is 110. And you can observe his chest wall movement. And I'm going to show you this video now, and we're going to determine his APGAR score together. So give me just a second to bring that up real quick for you. And in your PowerPoint, you do have the APGAR scoring on there for you that you can use as a reference while we're doing this together. baby Barrett.
Well done, babe.
Superstar. Oh my God. That was great. That was tough work,
Okay, so baby Barrett, here he is. We can see his heart rate we know is above 100, so that automatically gets him 2 points. His respiratory rate, he has a mildly good cry. I wouldn't say it's very vigorous at this point, so I would give him 1 point for that. His muscle tone, he is flexing both his arms and his feet, so I would give him 2 points for that. His reflex irritability, she is cleaning him off with the towel, but he's not really responding with a vigorous cry. I would say he is grimacing and he is intermittently crying, so I would give him 1 point for that. And his color, his body is pretty pink. His hands may be a little pale, but for the most part he looks pretty pink, so I would say 1, 2, 3, 4, 5, 6, 7, 8. He gets an 8. You maybe could argue that his hands and feet are a little pale, so maybe just 1 point. So anywhere from 7 to 8, I would totally agree with you on his APGAR score. He is normal. Again, you remember anything 7 or above means he does not need any type of intervention at this point. So this is baby Barrett. So I'm just going to show you a couple brief demonstrations real quick on how to measure the infant's head and length and do a few vital signs. Alright, so we have this little girl here. We're going to measure her head. You want to measure the largest portion of the head, so that's usually right above the eye, kind of around that brow line. Measure around. And her head is about 12 centimeters. And then you want to measure from the tip of the head. Some infants have a lot of hair, so you want to make sure you're really getting the top of the head. And then drawing down. Extending the heel of the foot. She's about 13.5 centimeters long. Vital signs, you want to observe her respiratory rate before you do the heart rate. Infants tend to cry when you place the stethoscope just because it's a little chilly. So observing for a full minute of her respiratory rate. Left midclavicular, feeling for her apical pulse. And I feel it. Now I'm going to listen here for about 30 seconds. And I have our heart rates above 100, so we're good. Axillary temp. I think this is pretty self-explanatory. And then we can visualize that the light reflects from the light at the top of this room is equal in both her eyes. And then using my ophthalmoscope, I can assess for the red reflex. And she does have a red reflex in both eyes. So that's just a couple of the skills that we talked about earlier with vital signs, just to kind of give you an idea of how to do those. If you have any questions at this time, I'm happy to take your questions, and there's references from this at the end of the PowerPoint. But other than that, thank you for listening to me today.